pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you very much. Welcome to the May 18 Messina Town Council meeting. We have a pretty busy agenda. We're going to try and move through it relatively quickly, as we always do, but before we do that, we always have a 15-minute public comment session. During that session, anyone's allowed to speak to address the board. We ask that you stand and state your name and address for the record, and keep your presentation, your comments to 3 minutes, and that you only comment once in the 15-minute time period. So with that, with that said, does anyone like to make any comments during the public comment period? Okay, let's get right to the agenda. I'm out of practice getting my papers in order. Here we go. A resolution to accept or reject bids for a Chevrolet half-ton pickup truck extended cab 2003 with mileage of 105,553 miles. I'm not going to read the VIN number. This is a truck that's no longer serviceable for town purposes. The high bid was $362 from Bill Kearns.
I move that that be accepted.
Second.
Motion and a second. Discussion. All those in favor signify by saying aye.
Aye.
Aye. Opposed, same sign. Abstention, motion carried. I guess we could have one resolution for both, sorry. We also have a Sterling L9511 heavy-duty dump truck, 2001. There's also been deemed surplus, 132,000 miles. And as is condition, and the high bidder there is William Brennan for $5,280. Both of these have been recommended by the Highway Superintendent Frank D'Agostino to be accepted.
Move to accept.
Second.
Motion and a second. Discussion. All those in favor signify by saying aye.
Aye.
Opposed, same sign. Abstention, motion carries. We also have a resolution to reappoint Richard McGinn to the Messina Electric Department Board. There was some difficulty in getting his oath of office signed within the 30 days, so it's a formality, so we need to reappoint him again.
So moved.
Second.
Motion and a second.
Oh, who wants a second?
Here.
Take it back. Give it to Miller. He's
He's low on me.
Yeah. Discussion.
Yeah.
All those in favor signify by saying aye.
Aye.
Opposed, same sign. Abstention. Should have been a discussion period, but thank Mr. McGinn for his past service and look forward to his future service. We appreciate that. Make sure you sign your oath so we don't have to do this again, okay?
Congratulations, Dave.
You have to stop by the town clerk's office.
He's the only one. He's the only one. They use all these acronyms at the MED. I told him more than the United States Army. He's the only one who knows what they are.
That's good.
We can't get rid of him then.
No. A resolution authorizing the supervisor to sign a library, a lease with BOCES for space in the Messina Public Library. You can see there's a little bit, some different terms, a little bit of an increase in that lease. The rent will now be $350 per month for 16 and 17, $375 for 17 and 18, and $375 again for 18 and 19. It's a 3-year lease. And they've been there, they have, it's, what am I trying, work, it's an employment station where folks can come and get their resumes updated, work on their resumes, et cetera, et cetera. It's been a good asset to the library thus far, I believe. I think it makes sense to continue it.
It's also a GED program.
GEDs, right, that's right.
Computers.
The computer stations, absolutely. All right, I have a motion to authorize the supervisor to sign that lease, 3-year lease.
So moved.
Second.
Motion and a second. Discussion. All those in favor signify by saying aye.
Aye.
Aye. Opposed, same sign. Abstention, motion carried. All right, next up we have a resolution authorizing the supervisor to sign change order number 1 and final for the Messina International Airport T-Hangar Taxi Lane project. It's a net change of $85,757.14. The details are in your packet. Oh, it's a minus? Oh, a credit, I'm sorry, okay.
So moved.
Second.
Motion and a second. Discussion. All those in favor signify by saying aye.
Aye.
Aye. Opposed, same sign. Motion carries. Resolution, approved to pay the town's share of preventing workplace aggression, bullying and violence training, which was a workshop that, we held jointly with Messina Electric Department. It was a $3,200 bill, our share was $1,600.
So moved.
There's a motion and a second.
Second.
Motion and a second, discussion. All those in favor signify by saying aye.
Aye.
Opposed, same sign. Abstention, motion carries. Next up, New York State Nurses Association, Messina Memorial Hospital. Who's on with that one?
I am. My
Okay,
name is Tracy Telber. I'm from Governor, New York, and I'm the program representative for NISNA. We wanted to take a little time tonight to discuss our staffing at Messina Memorial Hospital and give you a little insight on what's happening as we see the progression of moving toward privatization and the effect that that's having on our staff. I've put together just some information for you guys I can talk so that you can have it. Just some outlines of information for you.
Thank you.
We have several RNs and CNCA members here who can give some specifics, but I want to just give an overall outline of where we are. First, I want to say that the hospital has been very busy over the past several months, and that is a very good thing. We are seeing much higher numbers of patients coming through the ED. We've had days when the beds on the floors are full. We've had patients waiting to be admitted, and that's a very good thing, and we are all very happy about that. It shows that this community is relying on the hospital. We as staff want to be able to give excellent care, and we've been working really hard to do that. As we've seen the increases in the patients coming through, it's required of our staff to work that much harder, and we've been doing that, and we've been doing a very good job at that. But tonight we want to just discuss a few of the concerns that we have in our ability to continue to provide that good care to the community. Mr. Wallabin came to you in March. Some of you had asked some questions about the current staffing, about recruitment and retention. When asked about employees leaving in that meeting, his response was, and I quote, that employees are always coming and going. Turnover rate's a little higher, but it's no dramatic difference, is what was said. We're here tonight because we feel it's necessary that you hear from the employees and not just the CEO about that issue, because we have a very different answer to that. Mr. Gray, at that meeting in March, there was a time when you seemed a little bit confused when asked, and you asked about whether people are leaving to chase money or if it was because of the pension. But I assume that you actually do understand what's going on. For years, our members have worked at Messina Memorial Hospital making significantly less money than other area hospitals because it had a good retention or a good retirement plan. That was the trade-off. We'll make less money because of the pension. But because of the movement to privatization and the loss of that retirement going forward, there's no longer an incentive to work for less pay. People will, and they are, leaving that hospital to chase the money. There's no reason not to anymore. I've provided a compilation of documentation that reflects the current staffing, and it is at the point now where we're concerned of it being a crisis on a day-to-day basis. In the packet, you will see that there is an RN comparison of wages for area hospitals. So if I could direct you to that box.
That's the first,
That's correct.
okay.
Yep. So you'll see at year 8, for example, that there's not a huge difference in some of the area hospitals. So for folks that don't have it, at 8 years, a registered nurse at Messina Memorial would make $33.13. At Claxton Hepburn, it's $33.32. So they're very close. Camp Potsdam, however, it's $38.75. Alice Hyde, $36.34. Samaritan, $36. So there are some differences. What we need to know is, though, that at all the other places except for at Messina, there's another step, at least one step, where you don't just get across-the-board wages, but you actually get a step for your longevity of your length of service there. So at all the other places, at step 11, for example, you would not only get the across-the-board that was negotiated for that year, but you would also get another step increase. What that means is that for an employee with 11 years of service, for example, if you work at Canton Potsdam Hospital down the road, you're going to make $43.11. But at Messina, you didn't get that step increase. So your $33.13 plus whatever those 2% or for 3 years was 0 for your across-the-board wage increase. That's where the difference comes in. The more long-term the employee, the more significant the difference. So what we're talking about is long-term employees who are skilled, who are trained in all the areas, who have expertise on their units. These are the people that we're talking about making $6, $8, $10 or more an hour less. And they've done that because they care about their job, they care about this community, but also because they had a terrific pension that they could count on. With that gone, I assure you, because there will be testimony, people are going to leave. Your experienced nurses are planning on leaving. One of our nurses received 4 text messages today asking for letters of recommendation from their fellow RNs because they're leaving. That's a problem. So just the wages is just the one part of it.
Before we move on
Sure.
from wages, I just
Sure.
wanted to clarify one thing.
Sure.
So if we take 8 years plus the current benefit package, pension now, Sam, is what% of
How much does it cost?
on a dollar? Yeah.
15% right now.
30 how much?
15% right now, long-term projection is 12.2% for tier 3 and tier 4.
It's
7%
15% right now. So
7.2 for tier 6. And if you, I sent you the math before, you cumulate all the figures, it comes out to about 10% overall between the tier 6s and the tier 3 and 4.
Okay.
That's long-term.
So if it's at 15% now, last year was twice that, I believe.
The highest it was I think 21%.
I know that we calculate town benefits at almost 50% total benefits. And they might be a little less than because of your
So you're adding in what the pension benefit is? Because I didn't add in what the pension benefit is.
No, but that's my point, I guess. If you look at total compensation, it's easy to look at, the dollar amount per hour, then we look at total compensation.
But I didn't add in total compensation at the other places either. If you want me to do that, that would be
3% at Canton Potsdam Hospital, maybe.
National average is 6.
Samaritan has a defined benefit plan.
Right, as is Canton Potsdam.
Yeah.
But anyway.
So if you'd like me to add health and pension to their wages, I can do that too. That's why I took those out and we're just talking about the
all right,
benefits.
okay, all right.
Okay?
Good.
All right. So, I also have in your packet, and you don't have to look at it now, but on the back of it, over 80% of our members, and it's hard to catch them because they don't get to come to a lot of meetings when they're volunteering to work 12 and 15 hours of overtime of pay, a petition that says we need safe staffing. To be able to continue to provide care to our community, we need better staffing. And that's also in your packet that you could look at whenever you get a chance to. But here are some of the facts. In the past several months, 3 nursing supervisors have stepped down because they cannot continue to demand our nurses to work under unsafe conditions. We have emergency room doctors who are demanding more nurses. That the current number of nurses are unsafe for their patients.
Oh, so the unsafe, that's what I was asking, the unsafe conditions, it comes down to staffing.
Absolutely.
Right.
Yep. Our focus is staffing on this piece of it.
All right.
And I'll connect it to why we're bringing it to you. Our nurses do not get breaks. It's in the contract. but they're not gonna stick somebody else to go and sit out on a break when they have patients to take care of. They rarely get their meal breaks in a 12-hour shift because they don't wanna walk away from patients and leave it even more short-staffed. They're even told now they're not supposed to have drinks on the floor for 12 hours on their workstations. But they do it. They do the work all the time. I had a nurse at my meeting this week who was going on vacation and was nearly in tears. She didn't want to take the vacation because she was leaving her floor so short she was almost in tears. When I had the meeting, I sat with 4 members early on in the morning. All 4 of them got phone calls to work extra shifts while we were sitting in our meeting. They had stayed over after their shifts to come to the meeting, and all 4 of them got phone calls the day after because they were so short-staffed. So in your packet, you will also see, for a second, I'll skip the ED schedule part. This paper here is called a needs list, okay? And that's a 1-week look at where there is no staff on a particular shift. There is no one available. Now, I'm sure you know that registered nurses are not required to work overtime unless under very specific circumstances.
Sure. I'm sorry to keep interrupting you,
No,
but
go
where
ahead.
did this list come from?
It gets posted on
Okay, so
floors.
that's what I'm saying, so this is posted by the hospital?
Yes,
Okay.
yep, it gets posted, each schedule that comes out,
Uh-huh,
they don't have enough people to fill the schedule, so they post what's called a needs list,
okay,
and they look for volunteers
okay.
to fill those spaces. So in a week, that's how many spots there are with no staff, and they rely on volunteers to fill those holes. Mr. Walben has talked from time to time about the needs to expand the ED, and nobody's going to deny that when you have a full emergency room, that means patients are there to get treatment. They're relying on the hospital, and that's a good thing, and we want to be able to give that care. But what you also have attached in this packet is a sheet from, and what's your name? From our chief nursing officer that talks about what the staffing should be in the emergency department. So she put this out. This is what we need for staffing in the emergency department. So a decision was made that this is what provides adequate care. Okay? So for example, early morning, we need to have 3 RNs on, and we need to have 1 ED assistant on. Okay? And so forth and so on. So the page behind that is just a snapshot of March. And I will guarantee that on the sheet in front of you that says how many RNs there isn't one spot where they think that 1 nurse is enough. But if you go to the schedule, look at the 1s. There are 1s where there should be 4s. That's not safe. That is not safe. So you can look further into those dates and review it, when you can. But that's what those 2 sheets are. So if we're going to expand the emergency department, where's the staff to do it? We don't have staff now. Where are you finding staff later? When, remember, you're at a wage deficit, right? You're at a significant wage deficit when it comes to experienced senior nurses. Where are you going to staff? So, Mr. Walben has said that in that meeting in March that when asked about the affiliation and what the word on the street was, he said that there has been some positive buzz about the affiliation, and maybe that's true in his office or wherever he's spending time, but it is not true on the floors, because the main concern is how are we going to get nurses to come here and stay here? We don't have a pension. We don't have a pension plan to offer. We're significantly below any area hospital. How are we going to get nurses to come here when we have 4 in one day writing letters of resignation? At the March meeting, there was a concern raised about the wages not being competitive, and I will say that Mr. Carbone is exactly right with what his response was. A 2% wage increase will do nothing to keep the nurses here. And that, especially when Mr. Weldon has said the alternative to the pension plan is a 401k type plan where there's a match from the employer. So an employee's got to find 10% of their wages when they're maybe $8 an hour below where other area nurses are. They've got to find 10% of their wages. They've had a 3-year wage freeze to put in a 401k so that the employer can match it 5%? How is that going to happen? How do you think that's going to happen and keep people here? They're not going to be able to find 10% wages to get any kind of pension benefit. If you just do the math, it's not going to work. Our retirement is important to us, and so are the wages. But right at this moment, our ability to give good care is at the forefront. We're doing the best we can, and it is a very good job. We are continuing to provide good care for our patients. Here tonight are just a handful of nurses, though, who have been working short-staffed, and they have a real fear that this is just the beginning of a very bad situation that's coming down the line. I have what we call protests of assignments, and I didn't put them in there because we get dozens and dozens and dozens of them. What it is when a nurse feels that the working conditions are unsafe to provide good patient care, or it puts their license on the line, it's a formal notice to their department manager. And it says, I feel that this is an unsafe condition. Supervisor's supposed to come up, look at it, evaluate it, see how do we fix this condition, and how do we provide better care. But we have situations where in the ED, we had a med-surg nurse was pulled to fill a management position. It's not even in the union, and they got pulled to be a manager because they used to be one, I guess. So therefore, the ER nurse had to go to cover their shift. 2 patients in the ED waiting to be admitted, but they were told they can't because there's no staff on the floor to take them. It goes on and on every single day. In the ICU, 7 telemetry units, 7 telemetry patients, 3 of them were on BiPAP, 2 nurses. 2. In the ICU with the sickest patients. Again, in the ICU, census was 8. They had a very seriously ill patient that required a one-on-one. The staffing was 2 nurses, 0 LPNs, and 0 nurse aides. Guess what? That one nurse had to go do the one-on-one. That left 1 nurse to take care of the rest of the patients. 2 RNs on in the ED. A patient was upset. She had to wait over an hour. We had 2 patients that next day, signed out AMA. They didn't get taken care of because there's nobody to do it. Those, and I can provide 100 of those if you want. Walk-in clinic. The walk-in clinic has been getting closed because there's nobody to staff it. That's money. There's no one to staff it, so you don't go. We have a cafeteria that gets closed on weekends and afternoons because there's nobody to work in the cafeteria. We have untrained and unqualified nurses who are being sent to fill holes in the ED. We have an OB nurse who's not even ACLS certified. She gets pulled to work in the ED on a regular basis. She doesn't know how to do it. She doesn't know how to run a code. We had a morning where there was a code and there were 3 people, a doc and 2 nurses. Guess what? Neither one of those 2 nurses were trained in the ED. What would have happened if one of your kids had to go to that ED when both nurses were taking care of a code patient and there was no other nurse to take care of your child who may have been having a seizure or something? I know it sounds like horror stories, I know it sounds like it's hard to believe, but that is exactly what is happening. And it can be painted as whatever you want it to be painted, but that's the truth of what's happening. Our nurses are in fear of their licenses. We are still providing great care, and that's not going to change. But we have to have staff to continue to do it. In the emergency room, in particular, in 2011, there was a rule, again, I showed you that how many nurses were supposed to be on in the emergency department. That was decided by management. That's what's safe. That's what you need. That was in 2011, And for that year, there were 11,591 patients come through the ER. When there were all those numbers that I shared with you. But in 2015, you're not gonna see one shift that has that many numbers on it. Not one shift has that staffing number. But the patients they saw in 2015 was over 16,000. That's 5,000 more patients than there used to be, with significantly less staff to do it. And the staff that's there is not even trained to be in the ED. They don't even know how to use the computers, some of them. So I'm just here to express our sincere concerns about the direction of the hospital. Mr. Waldman may be fulfilling the ambitions and the thoughts process that this privatization is the best way to go, it's the best thing to do. But what you're not hearing is what it's going to cost. It is costing nurses. It already is, and it's going to continue to cost nurses. We're on the verge of a crisis. And when Mr. Wallabin says, oh, it's business as usual, things are good, that is just not true, and we have nurses here to talk about that. So Kathy, go ahead. Kathy is the chairperson, and she's in the emergency department every shift that she has. So
Yeah. Hi, my name is Kathy Thomas. I am a nurse in the ER. I've been employed there for 28 and a half years. And I do want to start off by saying that we do have an amazing staff at Messina Memorial Hospital. We will always put the care of our patients first, regardless of any staffing issues that we have. We may let other things slide, like paperwork and non-important things, but providing quality care to our community is on top. One of the reasons we're coming to you is because over the last several months, we've had countless protest of assignments and unsafe condition reports that have been submitted to management. We feel that they are being ignored as we are not seeing the changes that we feel need to be made. I have personally been told it is a matter of perception. NYSDA has recently handed out bargaining unit surveys to start preparation for negotiations. I have currently received about 75% of those back. They were asked to list 3 key issues that were important to them. Everybody wrote safe staffing. Clearly, all of our perceptions can't be wrong. In the past 3 months, there have been at least 40 job postings for variable positions in the hospital. Administration has talked about expanding the ER and increasing the amount of telemetry beds. I agree 100% that we are in need of both of these changes. My question is, how are we going to staff for these increased services when we can't staff what we currently have? With the loss of our pension and lower wages, how can we retain the employees we have and recruit new employees when there is no incentive? As the local NYSDA president, I am overwhelmed by the amount of nurses who approach me with their staffing concerns, with feeling about their licenses being compromised, and about leaving Messina Memorial Hospital, and that really concerns me.
Hi, Janine Harrigan-Pierce. I'm the day shift charge nurse on the med-surg peds floor, and I've worked at Messina Memorial since 1991, which means I've spent the majority of my adult working career at that facility. I've seen many changes over the years, and times when we had to work together harder to maintain the best care for our patients. These are dedicated, hard-working people. Nothing is harder than seeing and feeling the frustration from my coworkers when care suffers due to lack of staff. And may I remind you that we aren't making toothbrushes, but we're caring for your mother, your child, your brother, or you. For those who believe that the ALC patients don't need as much care, they are mistaken. Doctors are required to see the patients once a week, not the nurses. These patients are awaiting placement elsewhere and are often with us for months. As elderly, they are usually confused and unable to care for themselves. This means they may be incontinent of urine and stool, unable to feed themselves, and may be unaware of their surroundings. Also, they may be monitored by alarms because of confusion or the inability to ambulate on their own. Some of these people attempt to wander off the floor and climb out of bed. They still need medication, often to be turned and repositioned. Maybe a complicated dressing change is required, or they are diabetic. Blood sugars are typically checked on people 4 times daily with insulin coverage. These patients are still people with personal needs and issues, with family members that can't be there, and they are concerned. We are constantly trying to keep pneumonia, bed sores, and falls at bay. Disturbing to me also is the projected loss of my New York State retirement and life insurance. I'm 51, and it's rather late to start donating to a new retirement system. And finding life insurance at my age is going to be more expensive than it would have been 25 years ago when I was younger and healthier. We need to feel secure in our job as nurses so that we can give you the best care as patients. Worrying about how many patients will be our responsibility on our shift, or if we're going to lose the benefits that we have worked so hard for, does not make us feel secure. Thank you.
I'm Tammy Kirby. I'm a ward clerk in Messina. I've been there 26 years. I'm a HUC. I've been in every department. I've worked in every department that HUC works in. I have other concerns that haven't been brought up yet also. The nurses are legally, what, you can staff only so many to a nurse?
No, there's no law.
So they have a max out number. Is
For
that
the floors,
right?
they,
Yeah.
for the floors.
And when they max out on med-surg, they admit to ICU. When they max out, even if there's beds, if there's not staff, you can't admit, and that's a money issue, right? So then you're losing money because you have nowhere to admit patients. Is that,
They have to be transferred.
yeah.
And that's
And
happened.
so you're losing money that way. And, that was one other thing I wanted to say. Oh, lab. New York State law says we have to have so many lab techs in the building in order for OR, ICU, and emergency room to be open. And we are facing a lab tech crisis right now, and we really need to be concerned about that, because you could, too many of them leave, we're going to be closing sections of the hospital, and we're losing money that way. If we have to close those departments until we get more techs, we're going to lose money. And I think those things should be looked at. So that's all I have to say, thank you.
I'm Carrie French with the CSEA. Again, with the nurses, the shortage, there's also CNA shortage. We usually only have 2, possibly at times have 3 CNAs on a floor. And this was brought up at labor management. With one CNA having 16 patients, 4 of them being complete total care. And that person cannot do anything themselves. They have to be fed, they have to be bathed, everything. The other one having 15 with 4 totals. That's too much. We've had staff now being injured and are still working injured because the people need to be cared for and there's not enough staff. Respiratory therapy, we've had 2 people put in resignations. One of them may have pulled it back. I don't know the status of that one yet. One of them's leaving to go to Potsdam because it's better hours for him, better pay. Doesn't have to work weekends or call. That leaves us with 2 registered respiratory therapists currently, right now. That's not enough. So there's other areas other than nursing, other areas in the lab that need to be looked at for staffing.
I didn't want to interrupt, right? Is everybody done speaking, or? Both of them I considered for a while, the lab and the nurses. And I had first-hand opportunity to experience, I think, both. I went to go to the urgent care center. I said to my wife, there's one car there, perfect. I said, I'll get right in, get right out. But it was closed. So went to the emergency room. I spent a long time there, a very long time there. I felt Kathy took care of me. I felt bad for her. I don't think she got a break for 4 hours probably. Stuff I had, went to the lab. I was concerned there wasn't anybody in the lab or enough people to, whatever, take care of it, and I waited a long time. And it's pretty discouraging, actually, very discouraging. The other thing is expanding the emergency room. I'm not sure where that really fits in with the redesign commission. I thought the emergency room was supposed to be less frequented. That was part of the plan to reduce costs. So I'm not sure where, you know, and maybe we can hear about that from Bob later on. The other thing I have to ask is Ryan Martin. I know Assemblywoman Russell had something on the legislation for staffing for nurses. Is there anything that you can comment on that, or is that, so, I mean, we've only got a month left in legislation, is that something that's gonna?
I believe the safe staffing bill is in that Ways and Means Committee, where it's been for the last month or so. That was about a week ago was the last I
Is
knew.
there a companion bill in the Senate, you know?
There's not, to the best of my knowledge, there's not a companion bill in the Senate. No, there is. It's been in the Health Committee for 2 years.
Okay. Anything else, Sam?
No, I think that's
Could I
about
ask
it.
a question? I'm sorry. Who is the lawyer handling the privatization of the hospital?
I can't remember the firm's name.
It's Bill Owen.
Denton.
Is it Bill Owen?
Denton, yeah, Bill Owen is,
Yeah. He's also the person who put into effect that we have to have private, all hospitals have to affiliate.
He was the architect, yes.
Yeah, I kind of think that would be not a wise choice for us to go with a lawyer that's going to benefit from us having privatized.
Can I ask a question in regard to that also with the
Sure.
privatization? Have there been further talks on who Messina is looking to affiliate with? Because it's my understanding that Vermont Medical Center already has Messina listed as someone to affiliate with, and I'm just wondering with all the district changes and state grants and funding and all of this stuff, how does that work when you could be part of a facility in Vermont? Because it's my understanding that there is already litigation starting about New York hospitals affiliating, and we have 3 of them up here.
There's what, how many so far already affiliated, right? There's 4 or 5 already.
CBPH, Messina, here, Malone, I mean.
Messina's not yet.
Well, your name is
Ken
with them.
Potsdam is.
Yep.
Plattsburgh, Elizabethtown, and
Yep.
one other one over there.
Alice
Alice Hyde's another one here,
Yep.
okay.
So our concern is about, as this district comes through
Well, how are
and
those
the
other
funding
ones
comes
doing,
in.
I guess?
No, I'm asking in the future, as it happens,
So you think all those other people are putting themselves
Yes.
in jeopardy as well?
yes.
Okay.
And there already is a review on the legalities of affiliating with a facility that's outside of this state and getting state funding.
Yeah, well, I'm
so-
sure Albany and Syracuse are assuming, I don't doubt it.
Absolutely.
Why wouldn't they? You know, I vowed a while ago that I wasn't gonna let the hospital hijack town board meetings again, but it's apparently happened tonight, which is fine. There's a nationwide shortage of RNs, isn't there?
There is, but not to a
Statewide
point of,
certainly?
not to a point of it being this way.
It's worse 10 years ago, right? It's
Oh, yeah.
increasing with the
Oh,
wage.
yes.
And when you talk about the fact that there are no 1 RN, there should be 4, how many other staff are working with them?
Oh, I said on some of these, in the ICU, there was no nurse, no CNA, no LPN and no CNA with them.
But on the other
Sometimes-
floors, on med surg, how many
sometimes-
LPNs, how many CNAs?
I don't have those numbers because LPNs and CNAs can't do the work of the RNs.
I understand that, right,
Right.
but I guess.
So when I'm talking about a
When I'm looking at a
shortage,
complete picture, I kinda think, well, gee, there's no RNs, nobody's getting any care, and I guess some people are getting a level of care, they may not be getting RN level of care, but I'm saying, there aren't people just sitting there wailing for help, I don't imagine, maybe there are, I don't know.
well, it is an issue. It is an issue. And usually sometime, on a floor where there's what, 20, 30 patients, there's maybe 2 CNAs.
Is there a lab tech shortage as well?
Yes.
Everywhere, not just here.
Oh, yeah. But, okay, so I guess what,
But our
My-
concern is
what our concern is here and how much worse it's going to get with this affiliation,
I
with
understand
the
that concern,
privatization.
but I'm saying if we're lacking certain specialties, and there's a shortage of those nationwide, we can't just make them up, right?
No, but you can make it worse by privatizing and taking away a pension that people have come to depend on. That's the problem.
The other, thing that, I found interesting is the chart you showed us, all those other hospitals are private, not-for-profit.
Yep.
Which is where Messina Memorial is headed.
Correct.
So one would assume that wages will increase here,
By 2%, according to Mr. Weldon.
One will assume that there will be a pension, it may not be a state pension.
Right, that the employee has to put in 10% to get 5% from the employer.
Whatever, however, that's negotiated, right, or whatever you negotiate.
Well, that's what they already said was their
And I'm
proposal.
not gonna negotiate contracts.
What's that?
Last question I have for both,
Oh, and loss of life insurance too, yes.
last question I have for both Nurses Association and CSEA. Have either of you requested special legislation to allow the private not-for-profit hospital to buy time in the pension system for anybody who's on the cusp of a milestone? Have you introduced it yet? Is NISA, or asked her to be introduced? Have you requested for anyone?
NISNA is working with Assemblyman Russell right now,
Has
trying to get
that
something done.
legislation been drafted yet by anybody?
As far as I know, it's in the process.
But the window's closed, I think. I don't think they're drafting much legislation
Okay.
after last week or this week, correct? So nothing's happened thus far. How about CSE? Have you asked anything for any special legislation yet to protect your members and
We're
help
not
them?
websites yet. And
That's right.
As far as I know, you, in December,
Yeah,
said
we know
you
it's
still have to
funny.
revote.
That's
When the hospital finally gets all their information together, you guys have to revote whether it's private.
So the answer is no.
No, Addie
Okay,
Russell's
thanks
working
very much.
on
That's good.
affiliation legislation that we asked for prior.
Why wouldn't you want to help your members out in the event that it does become private?
Why wouldn't you want to help the staff that's taking care of your family right now?
I think that's happening to some extent, maybe not to the extent you like, obviously. You're obviously negotiating a contract, that's part of the reason you're here.
We haven't even
understand.
started
I appreciate
negotiations.
that.
We haven't started negotiations.
Well, you will soon. Right.
At some point.
Okay, all right. And again, not wanting to let the hospital take this over, I have to let Ms.
Oh,
Waldman
I'd be glad
respond
to
to
hear
any
what he
of
has
these.
to
Let
say.
me add one more thing, Joe. I've heard, not just from the unions, but other staff at the hospital, that there are shortages of nurses in various
Don't doubt that.
departments.
I agree.
And using nurses from other departments that aren't trained in that department can be very dangerous, and there was concerns. It wasn't these people, it was
Right.
other people at the
I
hospital.
understand that, yeah, and I would agree with that. I would be concerned as well.
One more really quick question, or not question, comment. The 2% raise that you guys are talking about, I clarified that in labor management because Bob had mentioned the 2% that was budgeted for increase in salaries. It's not for raises. It is for step increases and longevity and new hires. It is not cost of living adjustment. They're not across the board raises.
Those are contract details that I assume you're gonna work out.
So, thank you. First, let me say I'm disappointed that our staff has come to a public session to discuss matters that could rightly be discussed at an internal forum, which already exists, it's called the labor management meetings. And the most recent labor management meeting was canceled by NISA. The most recent, prior to that, was held in February. So I'm at a bit of a disadvantage because I don't have your information in front of you. Let me clarify some points. It was stated earlier that the hospital is busier. That is true in the emergency room. In terms of inpatient admissions, we are approximately 500 fewer inpatient admissions this first quarter of the year than last year. That's a fact. People may have different opinions about the facts, but you can't make them up. All right? Additionally, it is true that there are protested assignment sheets. We go over them every morning. And we try and evaluate whether we've made the proper decision in terms of staffing. We've had a run recently of an inordinate number of call-outs. One day we had
What's the call-out?
where someone's on the schedule to work, we expect them to come to work, and they are either sick or have some other issue that they can't report to work. This happens in every business. One day, 2 weeks ago, 11 staff members on one shift called out. There is no way that we have a bullpen of staff sitting around to accommodate that. You cannot run a hospital with a bullpen of people waiting to be called. This is not a school district where you have substitute teachers. Okay, we have added people, we have added staff to our per diem pool. And in fact, in certain areas, we are providing more hours of care this year than we were last year. And we've added positions so that we can eliminate tasks that are non-nursing tasks, so nurses can function and do what nurses do and don't have to transport patients, go run the lab specimen, look up the radiology report, and all those kinds of things. So we are working actively to improve the processes so that nurses can concentrate on providing nursing care. Just recently, we looked at our staffing, and we comply with the state regulations on staffing. There's no question about that. You cannot make up a fact. That is the fact. And we take that responsibility very seriously. It was stated earlier that employees are leaving. Our turnover through the first 5 months of the year is 3.5%. If it continues at that rate, which no one knows whether it will or not, that would end up the year less than the prior year. It was stated earlier that people are being injured. We've not had one reportable lost work time injury in 2016. So I don't know what facts people are making up, but those are the facts. Finally, we do believe nurses are important, and it is true that nursing is a profession where there aren't enough nurses. Just this past week, we've received commitments from 3 specialty nurses who are coming back to work at Messina, who had left, found out the grass wasn't greener elsewhere, and they're coming back to work for Messina, and they'll be put on the schedule in the month of June. And additionally, we continue to recruit, and so most recently we did something that Messina Memorial Hospital has never done before. We had a graduate nurse recruitment fair, and we have 12 applicants from that recruitment fair. We're currently vetting them. We expect that we will probably make offers to 8 or 9 nurses, and they'll come on as graduate nurses once they pass their boards. Then they will be oriented and put on the schedule as nurses. So we're actively recruiting. So the picture that's painted, that we are not responding to the staffing needs, is not entirely accurate. The picture that the hospital's busier, it is true, the emergency room is busier. I just want to correct one factual error. Last year, we didn't hit 16,000 visits, it was 15,643. Okay, so admittedly, only a little less. Okay, so we are actively working on making sure we have the right staffing, and we will continue to do so. It's unfortunate that the staff has come before you and taken a topic that is extremely complicated and tried to make it seem very simple. My final point. The union has the option to request negotiations. I want to tip my hat to CSEA, at least they have done that. NISNA has not. What have they done? They've decided to come to you rather than follow the established internal channels of either labor management meetings or requesting negotiation and tried to basically scare you. That's what they've done. So I would suggest that you recommend to them that they follow the internal processes that are well known in this organization. It's called labor management, and if they want to negotiate the contract, they're more than happy to request that, and we will entertain that. I'd be happy to answer any questions.
How's the privatization coming?
We are continuing to work on that. We anticipate that we'll be doing things through the summer, and our objective is to try and get privatization done by the first quarter of 2017. So until that time, I would state that everybody has the same pension they got now, and in fact, we've committed that there will be a successor pension plan. Just like 6 states have converted their pension plans to a combination of defined benefit and defined contribution. We will be doing the same. The issue about life insurance, we're clearly going to offer a life insurance benefit. We're clearly going to offer a health insurance plan. We've already committed to that. There's no mystery about that. Now, we haven't worked out all the details, but we've said we're going to do it. And unfortunately, those are the things that make the movement to privatization more complicated, and we don't think it's going to be done until the first quarter of 2017. And just as a matter of record, the law firm that's assisting us is Denton's. Benton's is a national law firm, international law firm with expertise in healthcare and corporate governance.
And the last question I have is that company that you hired to do the evaluation of what the hospital's worth, is that on board now, working or no?
They are in the initial stages. What we have done, we've set up a secure data room into which we dumped 20 years worth of information about the hospital, basically, and they are going through that and using that in their process of determining the valuation. It will be several months yet before we have that.
I don't have a question, but I do have a comment. And it's, that I just got to say, and of course everybody is when you say that, but I don't feel qualified at all to be taking in the information that you gave us tonight. You know, I think that there is internal procedures, there must be. I'm not aware of what they are, but you know, I tried to write down, I tried to take notes, and you guys spoke too fast. You know, I would encourage that you go through the internal process, go through the hospital. I also don't like venting our dirty laundry from what you perceive the problems are at the hospital out in public. I would much rather have it done through the...
We have brought it up at Labor Day
And we did in February, and Mr. Weldon wasn't there. His Human Resources Director was there. The reason we're bringing it to you, with all due respect, the reason that we're bringing it to you is because at this point in time, the town board does have a say in what happens to that hospital. And we have sat in these meetings and listened and listened and listened to Mr. Wallabin's reports and projections and slide presentations and all of these kinds of things. But we feel that decisions being made now and going forward with this privatization, you need to have all of the information available. And when he is at a town board meeting and is saying, when asked, what's the staffing like? Oh, people come and go, but there's no big difference. You need to know the other side of that. We have gone to labor management meetings, and we do use the vehicle of protest of assignments to have the supervisors come down and review every single case when we think a patient is not safe. And it doesn't work. It doesn't work. And the reason we brought it to you is because as this privatization moves forward, it's going to get worse. And then it will be a problem when there aren't people to staff the hospital. Mr. Wallabin said that he had 11 call-outs in a day. Well, I'm sure there's over 100 employees there on any given day, and you had 11 people call out. That's pretty good if you ask me. When you talk about how many less patients,
when you're short.
how many less
11
patients.
nurses called out.
How many-
That's virtually the entire shift.
How many nurses
No,
are there?
Okay. Well, we're being told that's not true. When you talk about there being less admissions than last year, that's because there are times when patients are being transferred out because there aren't staff to take care of them. And that's the truth. They're being transferred out of the emergency room. They don't want to call it a diversion because then the state gets involved, is my understanding. So what they do is call other hospitals to take their patients because there isn't staff on the floors to take care of them. That's why the inpatient numbers may be down. So for all of the things that is being said, there's a reason why some of that stuff is happening. We're simply bringing it to you to make you aware that it is going to get worse. We have 80-some nurses, 90-some nurses, and it is an overwhelming conversation that they're going to leave. And we just want you to be aware of that because then it is going to be a town board problem. It's going to be a town problem. You're not going to have staff to take care of your families. And that's why we brought this forward.
Anything else, Steve?
Just that I wish there were a better avenue to
So
There is,
do we.
there is a hospital,
we,
I mean,
so do
hospital
we.
board, the hospital board sets policy with the hospital, you're aware of that, right?
Pardon me?
The hospital board sets policy with the hospital, you're aware of that, right?
You know, I mean, I would, I mean, if there's an indication that the hospital staff is not doing a good job, which there is, then I think there are other avenues that rather than coming here. I mean, I try, like I said, I tried to take notes.
It's not doing a good job. We
Well,
were
the care,
portraying
the
that the
care
hospital.
is suffer, I think is what you meant to say, right?
Oh, we didn't say at one point that the care is suffering. It's that
Yeah,
we're,
you kinda did.
Well, our point is that we're
You said the shortage
providing,
of nurses are putting people in jeopardy, that's exactly what you said.
it's putting us in jeopardy, our licenses. We're working overtime and doing everything we can to ensure good quality care.
I thought you also said it was jeopardizing patients as well.
If we have people leave, it's going to, that's what the
No, but
point we're
there's a
trying to
shortage
make.
now is what I'm saying. There's a shortage
What
now.
I have said from the very beginning is that the shortage is bad now, but it's going to get to a point when we're not able to provide the care that people need. That's the point,
Because they'll leave a private Messina hospital to go to a private Canton Potsdam.
to make more money, yes,
If the wages aren't adjusted, I understand that part, okay.
significantly injustice.
Mr. Supervisor, it's, under labor management, does anybody from the board of managers sit on that? You know?
No,
I don't know, is it board manager?
no,
Okay.
no.
Okay.
Bob said the inpatient beds were down. What's the census been lately?
No, I said the number of admissions in the first quarter are down all over 500.
What's
And
the
it's
census?
not because we've been transferring patients out of the emergency room. The first 3 months of the year, the hospital was slower. We have transferred some patients out of the emergency room. In fact, we keep track of that. And it's far fewer than you would be led to believe. Most of the transfers out of the emergency room are patients that require a higher level of care. They need a cardiology service in Syracuse or Plattsburgh, or they need surgery at a certain level that we don't provide. But I admit, we had one weekend where we had an inordinate number of call-outs. We cannot mandate a nurse, that's against state law. And we had to move staff around, and we made decisions to triage patients out of the emergency room. There's no question we did that. You would rather we did that than to place a patient in the hospital in an unsafe condition. So I would say to you, that's a reflection of the fact that we are as concerned about the safety of our patients as the nurses who are here tonight. So that's what we've done.
Can you speak a little bit about the walk-in clinic being closed?
The walk-in clinic is staffed by providers, either a physician or a PA or a nurse practitioner. And there are times when we do not have a provider to be there, and that's when we close them. So it's not a program that we avoid, but when we simply don't have a provider, you know, physicians and nurse practitioners and PAs do things like take vacation. They do things like get sick, just like all the rest of us. And when that happens, we have our PAs and physicians already assigned somewhere else, and you cannot leave a group of patients and also cover a walk-in clinic. So we make decisions on that. And fortunately, we have an alternate. It's called the emergency room, which is what we had before we set up the walk-in clinic.
I know, but the walk-in clinic was supposed to be a big moneymaker. And do you provide, I mean, is the contract help in there? Is that what?
No, there are employees. They're staffed by our physician's assistants and by our nurse practitioners and by our physicians. Okay. And we continue to recruit for PAs and nurse practitioners. So, you know, we don't like closing the walk-in clinic any more than we have to, but you cannot run multiple sites when you don't have enough providers, period.
I know you brought on the numbers with you, but I asked with the census.
The census averages 24. Acute patients. On any given day, we'll have 5 or 6 alternate level of care patients, which are not acute. These are patients waiting either nursing home placement or to go somewhere else. And then we'll have somewhere between 3 and 4 patients in observation status. Some days 5 or 6. Observation status are patients for which the physician has not determined yet whether they have problems sufficiently severe that they have to be admitted. And normally, those patients go home the next day.
So that leaves basically 20 empty beds, so.
If you add that all up, it generally adds up to about 34 to 36 people in a bed. 24, 26 of which are acute care and the other mixture.
So if you're at full capacity, 50 beds, could that be staffed?
Pardon me?
Could that be staffed with present employees, 50 beds?
No. We haven't run over 40 occupied beds in ages. We certainly would like to run over 40 occupied beds, and if we could stop airing our dirty laundry in public, perhaps the community would have more confidence in us and use our facility. It's never a good thing to air your dirty laundry at home,
Well,
as
neither are,
Mr. O'Shaughnessy pointed out.
neither are rumors or neither is hearsay. Can you just explain a little bit the emergency room, enlarging the emergency room? My understanding is redesign commission calls for emergency visits to be less. How is that gonna help them be less if you expand the emergency room?
The redesign commission is about Medicaid enrollees. We serve patients who have insurance. We serve patients who have Medicare. We serve patients who have Medicaid insurance. So the redesign commission envisions a world where there will be less use of the emergency room by Medicaid enrollees because there are more doctors available who will take Medicaid. I don't know how familiar you are with doctors and their relationship with Medicaid in this county, but there aren't very many doctors who accept Medicaid as the primary source of insurance. So as a result, Medicaid enrollees have very, very few options for ambulatory services. They can't just call up a doctor's office and say, I'd like to come see you, I have a sore throat, I have an earache, I have whatever, and I've got Medicaid. Most doctors say, I don't accept Medicaid. So where do they turn? They turn to the hospital, and they turn to the emergency room. Now the state has embarked on this big plan called the Design and Incentive Program, which over 5 years is intended to reduce the use of the emergency room by Medicaid enrollees. And among other things, the state is putting money into recruiting more doctors. We're in year 2 of that program. We have 3 more years to go. So we're working very hard. In fact, I was on a phone call this morning, and I can tell you that there's a lot of work being done all across the North Country to try and make what the state wants to be done a reality, but it's a very challenging task.
So I guess I'm still not getting it. You're gonna enlarge the emergency room to accommodate more patients?
Well, the emergency room right now has 7 treatment rooms. We're seeing 15,563 patients. The design criteria at the state, if you were gonna build a new hospital with an emergency room, you would be allowed to build, for every 1,400 emergency room visits, you'd be allowed to build a treatment room. So you do the math. Divide 15,630 by 1,400, and that'll tell you how many treatment rooms we should have. If we were building new, that's what we should have. Even if you have the most optimistic view of what the district program will do in terms of reducing Medicaid use of the emergency room, we still are going to need more treatment rooms. So we have designed an expansion that adds 7 more rooms to our emergency room. It's a $6.1 million project, and we are out trying to find funding to pay for that $6.1 million project.
I guess I don't understand the advantage. It gets you out of the waiting room into a room quicker, so you wait in the room longer.
That's right.
Well,
Right, I mean,
clearly, if we add more space, we're going to be adding more staff. The emergency room volume continues to grow at a clip of 5 to 6% a year, and we believe that's going to continue to grow. So it's an important program for us. We need somebody to step up with $6.1 million. And if somebody wrote us a check for $6.1 million, I can tell you we'd be expanding this physical space in the emergency room, and we would be adding the staff to make sure that the space works well for all our patients and our staff.
So are you penalized for having more emergency room visits? That seems like it's against the redesign commission. Are you supposed to have less emergency room visits?
There's a complicated formula. The number of emergency room visits we have to actually reduce is 143. If we don't, over 5 years, reduce 143 Medicaid emergency room visits, in theory, the state can withhold some Medicaid money from us.
So, but you're increasing at 5%.
Right.
So is that 143 off the present number or off with the 5% increase?
Off the present number. So once again, the design, the district program is a very complicated program that people are trying to make very simple. I would like to give you a very straightforward answer. It's not as straightforward as people would lead you to believe. There are at least 10 moving parts, most of which a local community doesn't control.
Can I ask a question to that?
No, I actually, we've been over an hour here, we gotta move on. I mean, if the board's got something else, I'd entertain that. If you don't, then, I'm sorry, we have to move on. I mean, you guys had, what, 40 minutes in the beginning, I think, so he's had 15 or 20. We gotta move on, we got people waiting on the agenda, so I appreciate you being here. Thanks so much to the hospital staff, I know you do a good job, I go there more than I'd like. Although I challenge some of the things to play devil's advocate, it doesn't certainly mean that I don't appreciate the work that you do. And thank you, Bob, for being here, and Tina as well. Okay, we're gonna rearrange the agenda because folks are waiting, and I don't think they need to for some of this stuff. We're gonna move